Education, a joint venture between the Hawaii Medical Association and the Johnny Burns School of Medicine. Evaluation forms were distributed at the signing table. Your comments are very important to the planning committee and will be used to plan future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. Speakers are expected to disclose to the audience any real or apparent conflicts of interest that may have a direct bearing on the subject matter of the program. Dr. Greer has disclosed that he has no relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. So Dr. Mark Greer received his bachelor's degree from the University of Hawaii. He received his Doctor of Medicine and Dentistry from Tufts University. He has received numerous certificates and held many positions, too numerous to count. Currently, he is the Dental Director and Dental Residency Director at the Queens Medical Center. The dental clinic at the Queens Medical Center is at Punch Bowl, focuses on treatment services for medically complex and fragile individuals who are best served in hospital setting, including geriatric patients who may have limited access to private dental practices due to their complex medical problems or challenges associated with communication and or behavior. Please help me welcome Dr. Greer.
Okay, thank you. Can everybody hear me okay? Good morning and good afternoon. I was caught a little bit off guard, but it was my guard that was down. I actually thought this was a class that I've been doing periodically with the geriatric fellows. So I do have some copies of a couple papers I'm going to mention here. But I didn't bring it up for everyone, but I do have some available, and if anyone would like these sent to them, if I can get a business card or some other reference, I can keep that out. There we go. I just want to explain a little bit more about my background, because I am a little bit unique, and I explain this not everybody except myself, but just so you folks know, as you move into the future, kind of what you need to look for when you're looking for some dental support with a lot of your disabled patients. I spent a lot of time working in public health as a public health administrator prior to going to Queens Medical Center. Prior to going to public health, I was a resident at Queens Medical Center. So I came out of dental school. Dental school is standard, is 4 years, dental school. Any additional years are optional. So in order to specialize, you need to go on to some form of postgraduate program. I did a postgraduate program in general dentistry, which is not a specialty. But those programs are accredited by the American Dental Association, Commission on Dental Accreditation. And these hospital-based programs are called GPR programs, and we still have one at Queens Medical Center. Although we're suspending it at the end of this year, and I'll explain a little bit more about that at the very end. But GPR programs, or general dentistry, general practice residency programs, are hospital-based and provide dental school graduates with training and experience in working with medically compromised patients. Also working in a hospital setting, training in hospital dentistry, working with people with behavioral issues. But a big part of those programs focus on oral pathology, oral surgery, and oral medicine. So management of patients with special needs. There's a handful of programs around the country. One of them happens to be in Queens. It can be very difficult finding a general dentist who's comfortable working with disabled patients, geriatric patients, patients with mixed pharmacy, patients that may be medically compromised in some way, patients that are taking Coumadin. So a lot of times, very basic, pharmacology sometimes makes it difficult to find Carina and a basic family general practice office. So, you know, as you folks move forward and you do have patients that do have special needs, it's important that you know that, you know, that there is some variation in the training that folks have. Not everybody has advanced training working with people with disabilities. And sometimes that can be, that can create a barrier to access to care. We do have some, we have a degree of barrier to access to care for a lot of we have a slight barrier in that it can be difficult finding care for folks with low income, folks that are on public assistance. You know, one of the biggest concerns we have in Queens is folks that have limited access because of disability or because of concern about disability. Sorry, the cooker's not working. Okay, so the programs at Queens, we see a lot of disabled patients, as I mentioned. We also provide a lot of in-house services at Queens, but also for other hospitals. We see a lot of transplant patients, patients who are pre-cardiac, you know, being sent for cardiac surgery and other joint replacements, other significant problems. We see a lot of oncology patients. Queens has a what's called the Head and Neck Institute at Queens Medical Center, and we have a very, very high volume of oral head and neck cancer patients. And we deal with the patients pre-therapy, post-therapy. We deal with complications. We deal with their surgical needs. We deal with their prosthetics. We deal with their surgical stents, operators, and after oncology care. There we go. We are not, at Queens is not a low-income clinic per se, but Queens is very in tune with its mission, and no one gets turned away at Queens. So it's actually, it's an honor to work there, and for us to be able to serve the patients that we do. These are the two papers that I mentioned, out of, you know, all kinds of documents that are out there. These are very good general descriptions, nice brief summaries of geriatric care issues related to oral health that I wanted to share with everyone. Common problems that we see in the geriatric population: lack of third-party coverage. Medicaid in the state of Hawaii does not cover routine dental care. In the state of Hawaii, Medicaid, there's two categories of individuals in Hawaii under Medicaid, and that's adult or child. There's no disability categories, there's no geriatric, there's no special consideration for people in long-term care. If you're an adult, you're not eligible for routine care. It does cover emergency services, which is pretty much limited to tooth extraction. I spent a lot of time working in public health as a state health director in Hawaii in the past, working on public policy, working with the legislature. It is very, very frustrating that we were, in the almost 25 years I was there, we were not able to get the support of our legislators, local or federal, to appreciate that there are people that are categorically disabled that we need to tend to. Among those is of course the growing group of elderly. Likewise, Medicare does not cover anything for adults, for dental. So a big issue that we have is, and I'm sure you folks encountered the same, there's reference to dental versus medical. In my public health experience, there's three: dental, medical, mental. They just tend to categorically separate them out, but they all should be, one and the same. I already touched on limited access for medically complex or medically fragile individuals. Just because, aside from the financial issues, the comfort level that folks have in working with them. Patients have a higher pain tolerance, discomfort tolerance. I'll show you a couple of clinical pictures. It's really nothing new to you, but it still surprises me after all my many years of doing this, how much patients are able to tolerate and how much they accommodate to. Polypharmacy has a lot of impact on patients' risk for disease, for particularly caries and periodontal disease. Xerostomia, there's a lot of pharmacological related problems that come up that directly impact oral health and the risk of disease. And then dependence upon caregivers. All due respect to folks that are under the care of another person. For some folks, they really don't get the home care, the daily care that they need. Sometimes it's behavior related, certainly, and folks know what I'm referring to. Difficulty gaining access, patients being belligerent or combative. But very, very often it's just, folks like near guard down and oral hygiene is just not being dealt with. The most basic thing that patients need, and for now we'll just focus primarily on our discussion today related to geriatrics. People need consistency and they need intervention. They need the physical assistance, they need the mental assistance to get some hygiene done. Oral health assessment. Whenever we see patients, we're looking for, whenever we see patients from a geriatric perspective, we're looking for significant problems that they have. There are problems that are unique to folks with geriatric type disabilities. So we're looking at dentition, we're looking at joint issues, we're looking at palate, we're looking at the structure of the jawbone. Soft tissue, we're looking at gingiva, mucosa, soft palate, oropharynx, oral tongue, floor of the mouth. So these are all not teeth. So we're looking at a lot of things, and it's important that everybody in this room, on your routine examinations, you look at a patient's mouth, not be afraid to touch the patient, not be afraid to palpate in the mouth, and not look past the teeth. Okay? Symptoms, that whether the patient has pain, the character of the pain, and whether there are functional issues associated with that the patient can share with you. What problems are they having, whether it's patient or caregiver. Sometimes patients are oblivious, sometimes patients don't know because of dementia, but they also may be unaware that they're eating a certain way, but a caregiver can explain, when I see her eat, she does this. Does that mean anything? So when we do our evaluations, we're looking at everything and we're listening to everybody. And then of course the science. Does the patient have pain on palpation and manipulation? Abnormal We're looking for all kinds of signs of soft tissue and bony pathology. Abnormal color, size, texture, consistency, odors, and whether home care is reasonable and adequate. And we always try to take into consideration of the limitations that the patient may have. Truly, doing everything you can to appreciate and respect the caregiver, but at the same time, I tend to be very direct. If indications are that not enough is getting done at home. Biggest risk factor that is controllable, the two biggest risk factors that are controllable in a home care environment are hygiene and diet. Diet, number one, hygiene. Like I said, there may be limitations, but there's still measures that can be taken. So we must balance dental findings and treatment plans with everything else that's going on with the patient. We do see patients that have chronic breakdown. They have chronic caries. Rarely do we encounter geriatric patients that we evaluate that don't have active caries, that don't have some degree of periodontal inflammation. But is it really putting the patient at risk? Is there a need for intervention in the situation? You're probably getting that loud. Is there a need for intervention? Because there isn't always need for intervention. Looking at caries, tooth decay, there's actually all kinds of tooth decay. There's cavities, but to a trained eye, to dentists and hygienists, there's different forms of decay, and some are more aggressive than others. We're not necessarily going to treat everything that we see, because the benefit may outweigh the risk. And if the patient is comfortable, they're not at significant risk for infection. Sometimes we're not going to go, for instance, with a tooth like this, or teeth like this, we're not necessarily going to go in there and place aggressive restorations. I have encountered situations. I did just recently came across another one where it was a 93-year-old woman that came in to see us with dementia. We were able to treat her to extract some teeth that needed to come out. But she was sent to us to have the teeth extracted because the dentist they were seeing said he was going to put implants. So I told the daughter, how we felt about that. That mom doesn't need implants. Mom just needs to be comfortable, and patient's doing just fine. And if mom couldn't tolerate, in his office sitting still enough, cooperating enough to have the tooth extracted, she's not going to cooperate for it. So we always try to keep it, practical and as simple as possible for the whole family, because the whole family is always going to be involved. Periodontal disease is a complex, like tooth decay, like caries. There's actually a whole series of different diseases. Not everyone is susceptible. But those that are susceptible and can have really, really aggressive, essentially gum infections, periodontal infections. These periodontal infections extend down into the jawbone, affects the bone. Will resorb in those areas, and ultimately, lead to these long tooth appearances that people have. Teeth will eventually become loose. They would actually eventually fall by themselves if they don't get severely infected before that. More often than not, this is very painful, and patient will end up having pretty significant infection in their mouth to the point that they'll have necrosis. They'll have what those of us in dental typically call periodontal odor. It's a very distinct necrotic odor, which is associated with necrosis of both the soft tissue and the bone, around. So not everyone is susceptible, but those, as I said, those that do are susceptible. Even relatively healthy people. There may be people in this room, healthy and educated, that spend a lot of time in the periodontics office because just having a very, very difficult time, getting a chronic infection like this under control. It's often more related to susceptibility than individual negligence. Xerostomia, it has significant impact on elderly patients. Could be related to medications, as you folks all know. One thing that we see at Queens a lot is elderly with a history of head and neck radiation. Radiation therapy can be a wonderful thing. It very often results in long-term, down the road, delayed response complications. Xerostomia, reduction, fall off in salivary flow. It can be transient, whether it's due to medications or to radiation damage, or it can be long-term. But it is something that needs to be managed. Patients should, for radiation patients that can have significant xerostomia, generally recommend that they carry a bottle of water, bottles of water that everybody has nowadays. Which is a good thing that they're sitting on the water all day and they're taking it at the same time they're hydrating. We always recommend, whether it's medication or radiation, the patients stay away from sucking on lemon drops and things like that. That can, it wasn't that long ago back that there was a common recommendation. Is to suck on hard candy to stimulate the saliva, but it actually causes really, really significant, very, very aggressive pain. Other soft tissue diseases that we're looking at when we evaluate our patients. Mucositis and or stomatitis can be related to xerostomia. More often than not, there's a backdrop, there's other things going on, so it needs to be followed up on. Anyone with dry mouth with open lesions of soft tissue should be seen by a dentist that works with a lot of oral pathology or an ENT that's comfortable working with oral cavity. That also, just like dentists or ENTs vary, some ENTs are more comfortable than others. But it's important that consultation, unless you folks have a definitive diagnosis, you have a source and you have a means to treat it. I do recommend that you bring in someone else, another set of eyes to take a look and see if to help resolve these issues. To let them, one long-standing and unaddressed, really creates problems down. It makes the problem worse down the road. Okay. Candidiasis, prosthetic stomatitis, oral malignancy, precancerous lesions, it's important that everyone is comfortable looking in the mouth, looking at the teeth, but looking at all the tissues in the mouth as well. Tongue, floor of the mouth, oral pharynx, soft and hard palate. Precancerous lesions are common in Hawaii. We really have a significant problem with oral cancer. Our problems with oral cancer have increased in the last decade plus with the influx of Western Pacific Islanders that have been coming in. We see a lot of beetle nut related problems at Queens Center. And some of them are very early. I mean, I've seen, I think the youngest is maybe 22 years old with already aggressive oral cancer associated with beetle nut history. But we see a lot of young people with precancerous lesions, including some mucous fibrosis, which is a very, very debilitating condition associated with, you have it with a history of radiation therapy, but overwhelmingly we see it here with a history of beetle nut use. So beetle nut will short of cancer, oral cancer, will damage the mucosa to the point that For instance, the cheeks are so hard that the patient can't even open them up. I mean, we have a number of patients that have literally have a vertical interincisal distance of less than 5 millimeters. And they're getting by day to day like that. Some mucous fibrosis is irreversible. There's no treatment for it. It is absolutely destined to become cancer. But it's very, very important that patients be evaluated. Feeling tissues as well. You want to do visual exams. You want to do digital exams. Any patients that have significant difficulty opening the mouth, it should be 4 or 5 centimeters. They should be able to open it vertically. But patients that have restricted opening, I've met very, very few patients in my 30+ years that have significant enough arthritis in the joint that they can't move. But I've seen probably a couple hundred now in just the last couple of years that cannot open them up because their cheeks are hard, they're rock hard. So that's something that should be followed up on. Should be referred for ENT consult, ideally should be referred to the Head and Neck Institute, like Queen's Medical. So at least the patient can be documented and a baseline record established. Common symptoms of malignancy, sores in the mouth that don't heal, kind of obvious. Persistent pain in the mouth, sore throat, ear or facial pain. Sores in the mouth that are not painful is something that we see very commonly. So persistent pain, you have this submucosal kind of pain. You can have this precancerous, deep tissue pain, diffuse sometimes, that needs to be followed up on. But we see a lot of, one of the hallmarks that we see with big tumors on tongue and lip is that, it looks like it looks very, very painful, but the patient's really doesn't really feel it's not really not bothering the patient that much at all. So sores that don't heal, sores that aren't painful, something we want to watch out for. Thickening in the mouth. So I mentioned the submucous fibrosis will change the texture and consistency of all the mucosal lining. But I've met many patients now who have said they can tell something's wrong, they feel something's wrong. I've seen many patients who it's taken years for them to gain an oral cancer diagnosis because they've seen multiple people, dentists, ENTs, oral surgeons, who look at them and say, no, they can't find anything. So it's important that patients speak up. It's important that we're in tune with caregivers and family members. Because if somebody's consistently saying that they can sense something's wrong, it must be followed up on. White or red patches on the tongue, gums, gingiva, tonsils or lining of the mouth, difficulty in chewing or swallowing, difficulty moving the jaw or tongue, numbness. Sometimes the sensation they feel is just unusual. Sort of feels numb, sort of feels sore. Whenever we hear things like that, we really dig deep. Swelling of the jaw, loosening of the teeth, voice changes. Many folks have already encountered a situation where oral cancer, laryngeal cancer, or cancer of the throat. It's not detectable. There's no normal involvement yet, but patient and family will tell you they sound different. It's very slight, but it's different. It needs to be followed up on. Unexplained weight loss. Very common situation that we see is lumps in the neck, a lumpy mass in the neck. Okay. Lymph nodes. So it's very important that again, visual exam, digital exam. So feeling the patient all over, feeling for those cervical nodes, eliciting responses from patients. When I touch here, is that sore? One of the hallmarks for advanced oral cancer, big part of the issue with when I say oral cancer, of course, is all different types of oral cancer. But one of the hallmarks is, and ongoing concerns is late diagnosis of oral cancer. Often, like I said, there actually could be a lesion that's visible, but the patient's unaware of it. But also lesions, of course, that you can't see. And it's not unusual at all. It's very common that the first sign of oral cancer is a node, an unexplained unilateral node. Patient didn't recently have a cold or some kind of congestion, but there's a node. Very, very, very common sign that ultimately leads to a diagnosis of oral cancer, and by now it's metastatic because it's change of smell or taste. And then many patients who, same thing, the common story is they talk to the dentist, they went to a physician, they send them to ENT, and something's wrong, I can smell something, I can taste something. And it still ends up taking years to get diagnosed. But, patients, their taste can be thrown off. I've been involved with a number of patients who the smell they smell is actually necrosis. So tissues necrosing in the nasal pharynx, but you can't see it. And they're not feeling it because that lesion's there, but it doesn't really hurt them. But when they finally do go in and check, you have tissue breaking down in the nasal pharynx. And then bad smell or smelling is themselves. So it's very important that, any symptoms that persist for more than a few weeks that are unexplainable, such as that unilateral node with no history of the flu, needs to be followed up. Denture care, or remove denture care. Remove dentures after meals and clean them, and then put them back in the mouth. Always store dentures moist. And then we'll talk about denture cleaning in just a moment. So, common question. Sorry about that. Very common question, does Auntie need to take out her dentures at night? So if Auntie's had dentures for 40 plus years and she doesn't take them out at night, and she hasn't recently lost, come up with a deficit swallowing. If Auntie wants to wear her dentures, she can wear her dentures. So she changing that all of a sudden is not going to make a big difference. Although it might impact her quality of life. She prefers to wear them at night. Dentures do need to be removed after meals. Okay, as patients with dentures know when it's time to remove the denture, and they'll excuse themselves, go to the bathroom, and rinse it off, and put it back in. But Auntie might not be able to do that now. She may not realize that. She needs to clean her denture and put it back in. And that clean could be just rinsing it off, and then rinsing her mouth, because any food that's still in her mouth when she puts the denture back in is going to cause the denture to not seep, and retention will be affected. So dentures should be taken out. I've seen a lot of nursing facility patients. I've encountered a number of patients over the years that facility did not know they had a denture, and the denture had not come out in years. I've encountered full dentures, full acrylic dentures bonded with soft tissue migrated into the denture, then we need to take the patient to the OR and cut the denture out. I've encountered more patients with partial dentures that were not removed. Hygiene was poor. Caries, tooth decay developed around the clasps of the denture. Periodontal disease resulted in the teeth migrating a little bit. So now the denture could not be removed because the metal framework is into the undercuts of the teeth. And then we need to cut the denture out. So it's important to look in the mouth. It's important with all the care facilities that you guys work with. That's clearly part of the nursing assessment. Everybody knows exactly what's going on. Everybody knows that Auntie has denture, even if the family says they don't. Because I've also encountered numerous situations. I've encountered spouses who have insisted to me that, oh, my wife doesn't know I have a denture. Okay. So beyond the interview with the family, everybody should be looking in the mouth. There should be a really clear visual and digital confirmation going on to see what's happening with the patient. Denture cleaner, I don't recommend the denture tablets you see on TV. Commercial denture cleaner. I don't find that they work very well. I've never found that they work very well. I've never found that they were you're worth the trip. So long as to go by. The best thing to clean a denture with is 50-50 water and vinegar. Just soak it overnight. In the morning, anything that's calcified comes right out. Okay. You folks will encounter or have encountered dentures. You can see the white teeth, the whitish teeth. Now dentures are all acrylic. A generation ago, it wasn't unusual to have an acrylic pink part and porcelain teeth. But nobody uses porcelain teeth anymore because it actually causes other problems. So the denture is all plastic. If you encounter a denture that's, the teeth are whitish, the gingival tissue is pinkish, but there's a crusty material on there that will come off. It's not part of the denture. It's not supposed to be there. But chances are you're only going to get it off with the decalcified. That is calculus, just the same kind of calculus that forms of your teeth. That comes from food material that's trapped in the mouth and then is calcified from calcium that's coming out of the saliva. So the best way to remove that is to soak it overnight, 50-50 water and white vinegar, and in the morning it will come out. Okay. It's very common to see this kind of thing with patients, just coming into skillness, or just coming into nursing. They've been at home for years, and denture hygiene hasn't been addressed. Patients present with all this calcium buildup on the dentures. That should be removed in a simple way. Patients that have a history of candidiasis, oral candida, the denture needs to be addressed. So treating someone with medications and then reinserting the infected denture kind of just creates a recurrent cycle. So do consider that. And a simple solution, just like a teaspoon of chlorine solution, hypochlorite, Clorox, all the same, in a cup of water, and soak it overnight. And then, of course, washing the denture after that. Washing the denture is made of plastic. So it can be washed with a brush, it can be washed with dish soap. Toothpaste is nice, it makes it taste better. But again, it's a piece of plastic. So it can be scrubbed with dishwashing soap. Works well. Home care recommendations. Soft toothbrush, gentle flossing. As we get older, we tend to have gaps between our teeth that tend to be easier to clean with a toothbrush versus having a floss. But it's good to get in there with floss every so often and help patients really clean out, really debride, and clean the material out from both between their teeth and stuck under their gum tissue between their teeth. Okay? So home care, we also always recommend avoiding spicy and acidic foods, avoiding sugary foods and drinks, avoiding alcohol-based mouthwashes. Listerine is okay. The hype for Listerine, everybody should ignore the hype on Listerine. Listerine gives a sense that it works really well because it tastes like medicine, but it's actually really very, very irritating. So it's best to avoid things like Listerine. If people like Listerine, I've told them, It's okay, if you like it, you can continue using it, but half and half with water. Okay? But anything that's high alcohol content, it dries out the tissue. People that are zero stomach or tend to be zero stomach, it's going to exacerbate that situation. So in that case, I would always recommend against not this three. High fluoride toothpaste. There are some prescription strength toothpaste that sometimes we struggle getting the third-party payers to pay for. But there are prescription strength fluoride toothpaste that are available at all local pharmacies. So anyone with high risk for caries, so anyone who's zero stomach is going to be high risk. Anyone, when we look in their mouth, essentially doing that risk assessment, we can see that they're predisposed to aggressive decay. We're going to put them on Prevenant or equivalent generic. There's several generics out there that go by similar names. But Prevenant is the most common label name. So patients should use that twice a day. The best time to use it, the best single time to use it is just before dinner. And we instruct patients and caregivers, brush their teeth the best they can just before bed, and then the patient goes to sleep with a little bit of their teeth, and sits down their teeth, so it's a good thing. Custom fluoride trays, we don't use very often. Compliance for custom fluoride trays is pretty low. It's the kind of thing, so this is even with our cancer patients. I would refer with my oral cancer patients that I see every day. Like you said, we have high volume oral cancer patients, but I prefer that they go with something practical like Prevenant, and they dedicate that they're going to use it, as prescribed. What tends to happen with fluoride trays is patients try it for a little while, they don't like it, they kind of start slacking on it, eventually they don't use it. And then everything else goes by the wayside because they kind of give up. So I do make fluoride custom trays at times, but generally I don't, because for a lot of folks, there's just so much going on in their lives. Like I said, we try to keep it simple to the point that they'll comply, that they'll be able to do it routinely. Regular checkups every 2 to 6 months. This is for patients that are high risk. So my general recommendation for healthy patients is that they see the dentist annually. What I think everybody in this room has heard about 6-month checkups is it purely started as an insurance industry standard. There's nothing significant about that periodicity. So everyone should plan to see their dentist religiously, at least annually. On the risk assessment that we do with our geriatric patients, we'll want to see them more frequently, but generally it's going to be annually, and then we work back from there. So patients that are at high risk, recently had an infection, may have other chronic things going on that we don't necessarily want to intervene on right now, but we just kind of want to monitor, like 94-year-old grandma that, we just took out a tooth, and she has some others that may be a problem, but we don't want to put implants. We'll have a family follow up with us, say in a couple of months. At the same time we see grandma, we're going to do a cleaning, we're going to get her all cleaned up, ready to go, and confirm her status. Okay? But that's something everybody in this room can also help with, in working with folks that have these kinds of disabilities. For those that need a soothing mouthwash, Biotene is okay. Biotene is one of the over-the-counter mouthwashes that you can find in most stores like Long's or Walgreens. But I generally recommend salt water with a little baking soda in it, if they need it. Okay. Otherwise, I just recommend lots of water with meals. I recommend for those that have significant cognitive disabilities, I generally recommend hygiene at bath time. Recommending that, instead of getting too stuck on the periodicity of brush teeth 2 times a day, 2 times a day. You do it at least once a day, and do it good. Maybe make it part of a routine that's followed every day anyway. Sometimes it's very, very helpful. So, bath time, shower time, whether it's in the tub or it's in the shower seat, there's a shower head. You wash body, shampoo hair, brush teeth. Best you can. Sometimes the best you can is going to be very messy. Makes it that much easier if it's done during your shower time. To make it part of a routine, some people have found that it helps a lot. Non-ventilator, hospital-acquired pneumonia. So there's a growing push nationally to deal with oral care as it relates to risk of non-ventilator hospital-acquired pneumonia. There have been a couple significant studies by Sutter Health in California that have shown reduced rates of non-ventilator acquired pneumonia in their hospitals. So about 2 years ago now, Queens started an initiative where all patients with scheduled surgeries are seen by the dental clinic on referral by the APRNs in our pre-surgery center if they identify risk that they believe that they see associated with potential for materials being driven into the lungs during anesthesia. So we see patients with loose teeth, we see patients with active infections in their mouths, we see patients with fragile dental work, we see patients with significant active infections that in the past have been overlooked. So, and then within the medical center, there's a protocol that when patients go through our pre-surgery center, aside from being evaluated by us and then treated pre-surgery, so we can reduce those risks. So we're not necessarily doing all of the treatment, but we're mitigating significant risk factors that we see. For a pre-surgery center also, we're given a home care kit with instruction to use prior to admission for surgery. When they're admitted, they must leave their home care kit at home because it's contaminated. So on admission, they receive a new home care kit in the unit. All patients in the hospital are on schedule and prodded by nursing that they have to brush your teeth 4 times a day. 4 times a day is the hallmark that Sutter Health found worked the best. So the kit that they have, it has toothbrush, it has toothpaste, it has an oral rinse, but there's some other things in there as well. But so it's a little bit more complicated than it sounds. But within the oral care component at Queens of everybody who's admitted, in every room there are these kits that are given to patients, and then their oral care is supervised. It's a combination of rinsing, brushing, but it boils down to brushing teeth 4 times a day. Jury's still out at Queens on statistically, what they found so far, because Queens is following the Sutter model, and that Sutter model is kind of expanding around the country right now. But all indications are we have had significant impact, considering the big problems that we've intercepted before they go to anesthesia. So this is my last slide. So this is a situation that all of you folks have encountered. I see a lot of people like this, some with complaints, some denying any kind of dental problems. But in the past, your patients would present like this the morning of surgery, and the anesthesiologist would work to pass the endotracheal tube, pass all this gunk, to get down in order to intubate the patient. And then, extubate the patient, and then have the patient take a deep breath. So we have, fragile, we have broken teeth, little particles that can break off. In this example, we don't have any active drainage, but it's not unusual that there would be pus draining from multiple areas here. But I'm sorry, I'm not showing this to gross anybody out. It's the best picture I had, just to give an example of multiple problems. But it's real. And then a big issue is this plaque, this material that's stuck around the teeth. That can be calcified, it may or may not be calcified, but regardless of whether it is or not calcified, it is the kind of thing that absolutely, during or post-anesthesia, or in the medical unit, in the skilled nursing facility, that is just sitting there in a patient's mouth, and in the middle of the night they're sleeping, and a chunk of it goes down. So, plaque-related, oral debris-related pneumonia is very, very serious. I feel it's kind of been overlooked for many, many years as a significant risk factor. But these studies out of California, like I said, have identified it as a significant risk factor. And so now suddenly it's pretty apparent that we got to do something to avoid this. So in a situation like this, we would do a debridement. We'd be getting rid of anything that can fall off these teeth. If these teeth sitting on the upper front, if they're infected, when we look at the bone, if we can tell they're infected, we want to get that out before a patient goes for surgery. Okay. If they're loose, it's not unusual for teeth to be loose to the degree that just leaning on them just a little bit, they're going to displace. It easily goes into the lungs. Same thing with dental work, failing dental work. Things can break off and it can go into the lungs. So we see the patients, sometimes we have a week lead time, sometimes we have a day. Very more often now we have a day. And we'll bring the patient in and we'll at least clean up and get anything out of here that's loose that potentially, particularly for a debilitated patient, they're going to be impulsed, they're going to be impacted, and they're going to be taking their deep breaths. And, we don't want them sucking this material into their lungs. But like I said, this does directly translate into a situation a lot of you folks are dealing with related to your disabled patients. So that's something that should be shared, and that context should be shared with nursing staff, so they understand. Maybe better understand the reason why it's important that we don't have routine food particles, we don't have loose teeth. Any questions? Water picks, generally, or in geriatric? I don't feel like they make a difference. I've never recommended a water pick. There's lots of gimmicks out there. It's worth trying if you're curious, because they're inexpensive enough that you might as well try them if you want. But generally, I think people find them kind of irritating. Statistically, I've never seen a study that showed that it was actually better than floss or better than mechanical toothbrushing. Same thing with, same issue with mechanical toothbrushing. So $1.50 toothbrush versus $100 toothbrush. Sonic toothbrush. Sonic toothbrushes are nice. If you like it, it doesn't necessarily do better than mechanical toothbrush. They tend to be kind of irritating, so specifically with geriatric population. I generally recommend against, but with the same qualifying statement that, well, if you would like to try, sometimes for caregivers, if it's important to them, then I think they should try it. But they should also know that, they're kind of really irritating. They make a loud noise, so I always recommend that if you're going to try it on an auntie, you try it on yourself first. Because then you realize that maybe that's why she doesn't, if she hears it, she's going to push you away more than the other. So it's not the answer to anything, and they aren't necessarily better than mechanical toothbrush. They can be slightly better, although I've rarely encountered a legit situation to be slightly better in a patient that has really real physical disability, but at the same time really wants to do it themselves. So with supervision, maybe so if it works for them, that's fine. But generally, I say go with the less expensive. Simple, always a simple better.
Hi, this is Lauren Okoro, donating remotely. I have a question.
Yeah.
I have a patient that has a pretty large oral cancer on hospice, and his primary problem is bleeding. Do you have any recommendation on how to stop bleeding for patients with large oral cancer?
Is he bleeding from the tumor?
Yeah.
Okay. Have you guys tried silver nitrate sticks?
I have it, so okay, well,
Yeah.
that'll be good.
Yeah.
Okay.
You might try that. Is it? Where is the lesion?
And then right below the tunnel, the right side, under the tunnel.
Yeah.
And then
So-
I'm having significant oral pain, so oxycontin, go down and oral lidocaine, which
Mm-hmm.
has really a lot of pain with the kind of viral fever.
Okay. Has he been to see anyone recently about maybe debulking them a little bit?
I haven't, he did have an initial consult with ENT at Queens and then kind of just moved to hospice. So we could possibly send him back.
Yeah. Yeah. I would suggest sending him back, and because the symptoms can be dealt with. It sounds like the disease is to the point that it's not going to be curable. But the local area should be able to be dealt with. So it might be debulked a little bit, or ENT might just go ahead and use silver nitrate sticks to identify the spots that are bleeding.
Okay.
Yeah.
Okay. Thank you.
Yeah. Okay, next.
Thank you.
Yeah.
Since general practice residency is closing at Queens,
Yes.
who's going to care for nursing home, bed bound, or Medicaid?
So the general practice residency at Queens is closing at the end of this year after being open since 1960, 1959, 1960. We've had some problems with our facility that we're working on. So we decided to suspend for at least a year. So in the meantime, I plan to stay, and we're looking at hiring 2 other dentists, preferably people that have trained with me or with others at Queens, so we can maintain the same level of service that we've been having for some time. But we still do have some facility problems. And it's going to take another probably at least 9 months to fix those facility problems. The facility problems are related literally to the facility, examination, and average change. So there's a lot of patients that we have with our facility, but for special need patients, I don't foresee that we're gonna have a significant problem, responding the way we have in the past. And I'm sorry, I stumbled for a second just because there's a little wishful thinking here.
Are
But
there,
that's our intention is to maintain the service.
are there providers dental providers in the community that provide this kind of care other than Queens?
Not that I'm aware of. There are dentists that will go into facilities into skilled nursing facilities as consultants, but I'm not aware that I haven't encountered folks that actually do a lot. So, but I haven't heard of
Will, during this year, will you be in the same geographic location? Sounds like some things need to be worked on in the
Yeah.
facility, so or will you be elsewhere?
So right now we're working, we have 2 sites in Queens. Actually just this past week, we moved back into our dental clinic site, but we're still operating our same-day surgery center. So we do a lot of surgery at Queens also, in Baymont, our same-day surgery. We have a converted procedure room in same-day surgery, that's functioning as an outpatient. So we're definitely, we have our limitations, but we're up and running, and so far we're able to respond to the significant issues that come in. As I mentioned earlier, we're not a low-income clinic. As much as possible, we try to send patients that don't need to be treated in people, that don't need to be treated in a hospital. There's not a good reason for them either. They can be seen in community health centers. We try to send them to community health centers and other private providers, so that we can prioritize and we can do folks that arguably should be treated in hospitals.
Hi, I'm Dr. Takanaka. I also take care of nursing home patients. Thank you for coming today. Do you have any tips for caregivers of patients with severe dysphagia? A lot of times the families are afraid because they're always told, like, oh, thin liquids or water you put in their mouth, they're going to choke on it, or they're going to get pneumonia from it. Is there any way that I can give them some tips about regular oral care that would make it a little bit easier for them?
Well, one is, like I said, doing it at that time, serving and possibly leaning them forward so that things can trickle out
Yeah.
versus going back.
Mm-hmm.
Minimizing toothpaste.
Mm-hmm.
So you never want to use toothpaste like a commercial. So the commercial, they sell 5 times more toothpaste than 3 times toothpaste. So I recommend toothpaste out of toothbrush that just colors the bristles.
Okay.
Okay, so you'll get a big sudsy thing that patients would have difficulties doing. Another thing they can do is, rather than toothpaste, fluoride mouth rinse. You can buy over the counter, and use that instead of toothpaste. So a patient can brush, but they say it doesn't make a foamy, but it's harmful. Or there's risk for it. But for sure, one of them is having the patient or gently pushing the patient back so they are leaning a bit forward so that things come out rather than go back.
Thank you.
Has there been any attempts to add fluoride to the public water supply?
There's been many attempts to add fluoride in public water supply. There have been many, and it doesn't make it. I don't foresee that in ways that takes political will. We don't have that. Xerostomia is also a very complex situation. There are pharmaceuticals that can be used to stimulate salivary flow depending on the situation. Likewise, having something in the mouth, can stimulate, such as a xylitol gum, a non-sugar gum. It can help stimulate, but it's patient to patient. So it's something we're trying. If patients do want to use the gum, they want to use a xylitol-based gum. Okay. Gum is okay. Xylitol is okay. So xylitol can be effective in the lab at reducing tooth decay risk, but you have to consume it. I mean, literally like 20 minutes, 5 times a day, for that to really have an impact. But if folks would like to chew gum, so here's another one of the sustainable things. So if they find it useful to choose xylitol gum and it gives them some stimulation, that's nice. But chances are they're not going to do it every day. It's just going to, it gets old fast. But for salivary stimulation, mostly you're looking for PRN effect. If they feel like it would be good to use. So whether it works or not is dependent on that individual. So it's worth a try. And of course, assuming they don't have swallowing issues or anything like that, we're not going to worry about it.
I have one more question about, when you have the oral thrush and you said something about addressing the dentures, does that mean also soaking the dentures in a nice acid solution, or would the vinegar or bleach solution be enough?
No, not the vinegar, but the Clorox. Chlorine, hypochlorite. Yeah, the hypochlorite, I would use the hypochlorite versus the nice acid. Yeah, what you're trying to do with the plastic is to just kill it.
Is there a certain amount of days that you would recommend for that, or just in
Oh, I would do it, so depending on the patient.
Yeah.
If they have chronic candida, they have, it's a recurrent situation, and you always want to be vigilant. And, and treat the denture when you treat the denture. So it depends. It's just like an acute situation or like an acute transient candida, or something the patient has ongoing. If the patient has an ongoing, then yeah, I recommend that it be done ongoing. Any questions? So I do have some of those papers. Sorry, I brought it. But if anybody wants, if you can just leave me your information, I'll help you.
Thank you, Dr. Greer.